Okay. Welcome everyone to our FRAT training. This will be a breast cancer immunotherapy update. It's my honor to introduce our speaker, Dr. Melinda Telli. Dr. Telli is an assistant professor of medicine at Stanford University. Her research focuses on breast cancer treatment and survivorship. Her primary research interest is the development of novel strategies for the treatment of triple-negative and BRCA1 and 2 mutation-associated breast cancer. Other areas of interest include prevention of cardiac damage associated with breast cancer treatment and cardiotoxicity of anti-cancer agents. So please welcome Dr. Melinda Telli.
Hi, everyone. I'm very happy to be here to review with you an update in terms of where we are right now in breast cancer with immunotherapy. Take the next slide. Okay, and then the next one. These are just my disclosures relevant to this topic. Next slide. So I wanted to start off the conversation talking about something that we refer to as TILs. So these are tumor infiltrating lymphocytes. So the lymphocytes are major players in our immune system. They have a role, of course, in helping to fight infection, but importantly, in helping to identify and kill cells that are becoming pre-malignant or malignant. And we've really known for a very long time, just from looking at sort of standard breast biopsies under the microscope, just under a regular light microscope, we've known for a long time that there are some breast cancers that really have a lot of these TILs or immune cells associated with the cancer. Some tumors that are biopsied and looked at will have very few of these, but some will be highly enriched. And so we've known for a long time, and there have now been multiple studies that I've listed here, really showing that in breast cancer, and I'm going to specifically focus on triple-negative breast cancer because that's where most of this data has come from, we've learned that tumors that have more of these TILs have a better prognosis. And there have been some recent studies showing that for every 10% increase that is observed in TILs, there's about a 14% reduction in the risk of recurrence or death. Also interesting is that patients, tumors with high numbers of these lymphocytes seem to have better response to chemotherapy, and specifically to platinum chemotherapy, which is relevant for triple-negative breast cancer as well as BRCA mutation-associated breast cancers. So what I'm showing on the right is just sort of a section of a breast biopsy. Again, this is just an H&E section, light microscopy. And what you can see, which I know everything looks purple, but there are some more rounded areas that are sort of look a little bit more fluffy and light purple. And these are the tumor nests. So where that arrow, the long arrow that is going to the box that says iTILs. So these are sort of actual areas of the tumor nests that are sort of scattered in this on this slide. And there are some TILs that are actually directly in contact with the cancer cells. We call these intraepithelial TILs. And so you can see those there. They're right associated with the tumor nest. And then you can see that around the tumor nest, there is just the normal connective tissue stroma. And in some cases, we'll see the TILs that they're not necessarily infiltrating into the tumor nest, but they're sort of around the tumor in this stromal area. And so that's what we refer to as stromal TILs. We'll take the next slide. And so, one of the question is, what is it about different tumors that make them more or less likely to recruit these immune cells into that tumor bed. We know that tumors, of course, are characterized by genetic and genomic alterations. They have increase in the number of mutations compared to normal cells. And the thought is that these mutations that are specific to the tumor are really responsible for making the tumors immunologically unique. So the tumor may produce, have a genetic change in the DNA of that tumor that produces a abnormal protein that isn't otherwise recognized, otherwise produced in our body, and so that allows an opportunity for the immune system to recognize that abnormal protein as foreign. And if you look across a tumor, these tumor-specific mutations only really represent a fraction of the total number of mutations in the tumor, but we think that, again, they produce these abnormal proteins that serve as sort of neoantigens that allow the immune system to then go on and recognize them. Next slide. And so definitely if you look across all of sort of the major cancers, there is a range in terms of the number of mutations that we see in different cancers. You can see at the far right side, the cancers with the highest numbers of mutations are melanoma, lung cancer, bladder cancer, et cetera. Breast cancer I've circled here, and it's somewhere kind of in the middle, but on the lower end of middle. But you can see that even within breast cancer, there's definitely a range, that there are some breast cancers that have high numbers of mutations and others that have low numbers of mutations. But we think that, this could be sort of a guide for thinking about, how likely immunotherapy is to be of benefit across different tumor types. Next slide. And so where all of the action has been over the past several years has really been talking about these drugs that are targeting immune checkpoints. And we're going to talk a little bit more about what that is, but it's really been a paradigm shift in thinking about cancer treatment. This is a treatment that doesn't really target the tumor cells specifically, so we don't really care what it is specifically about a melanoma versus a breast cancer versus an ovarian cancer versus a lung cancer. What this treatment is trying to do is block some of the inhibitory pathways to unleash the body's anti-tumor immune response. Next slide. And so we've come to a point where we have a number of these immune checkpoint drugs that have become approved. These are all antibody-based drugs, and they target different immune checkpoints, such as CTLA-4. That was the first one in melanoma, ipilimumab. But where most of the work has been recently, and specifically in breast cancer, has been trying to target this PD-1 and PD-L1 immune checkpoint. And we have drugs, again, now approved in multiple tumor types, and I'll go into that a little bit more in the next slide. But why there's been so much enthusiasm is because these drugs have been definitely active in cancers that have been historically very difficult to treat. Melanoma, for example, is a cancer that when it's metastatic really has limited responsiveness to chemotherapy and has had traditionally a very poor prognosis. And so what we've been seeing are high rates of response in some of these historically difficult to treat cancers. And most importantly, these responses have really been durable. So for those patients who respond to these checkpoint blocking drugs, their benefit seems to be long lasting. We don't as yet have any immunotherapy drugs approved in breast cancer. Certainly where most of the work has been looking at triple-negative breast cancer in the advanced disease setting, and definitely proof of concept has been observed there, and we do have multiple phase 3 trials that are pending. There are additional studies right now moving forward in other breast cancer subtypes, as well as some interesting data looking at all of this in early stage breast cancer. Next slide. And so this is a table from a very recent paper in the New England Journal of Medicine that is really a review of kind of where we are with immune checkpoint blocking antibodies. And you can see now that there are 6 of these drugs approved. Ipilimumab, the target is CTLA-4, that's a drug just in melanoma, but you can see that all of the other drugs target either PD-1 or PD-L1. The 2 drugs that have really been most extensively studied are nivolumab and pembrolizumab, and you can see that there have been multiple FDA approved indications now in melanoma, lung cancer, kidney cancer, Hodgkin's disease, liver cancer, just a number of different tumor types. Next slide. And so we think that one of the big sort of features, again, of cancers that respond to immunotherapy is that they have these TILs recruited into the tumor microenvironment. So something about that tumor is making these immune cells recognize the tumor, and they are associated with the cancer, either kind of right up against the tumor cells in direct contact with them, or sometimes, in the periphery of these tumor nests. And we think that these cancers, if we just unleash the body's immune system, unleash these T cells, that by themselves as single agents, they could result in profound clinical benefit and durable clinical benefit. The situation shown here on B is sort of what we would refer to as a cold tumor or a non-immunogenic tumor. It's not very inflamed. There are not many immune cells that are recognizing this tumor. And so the idea is that if you go and give one of these immune checkpoint drugs to unleash the immune system, if the immune system isn't there, it's not going to lead to benefit. And so for these types of tumors that are thought to be more immunologically cold, the approach really needs to be to combine the immunotherapy with some sort of other treatment that could lead to an infiltration of immune cells in that tumor, and then try and activate or unleash them. And that would be the path to lead to durable clinical benefit. So historically, we felt that many breast cancers are, fall into this category, so that they're not very immunogenic. Again, we know that there are some of these breast cancers that are highly infiltrated with immune cells, and that those tumors have a better prognosis, but the majority of breast cancers are not heavily infiltrated with immune cells. Next slide. And so, as I mentioned, the major sort of immune targets that have been really super successful across multiple disease types have been these antibodies that try to impede this PD-1, PD-L1 interaction. And so PD-1 is basically a receptor that's upregulated on activated T cells. And so normally the job of this T cell is to come into the tumor area to recognize the cancer cell and kill it. But these cancers are typically smart. They can upregulate a molecule called PD-L1, and this can be upregulated either on the tumor cells themselves or in some of the cells of the microenvironment around the cancer. And basically, when PD-1 binds to PD-L1, it essentially shuts that T cell off. So the tumor can mask itself by upregulating this PD-L1, so that it is essentially sort of not seen by these immune cells. So it's the way that the cancer protects itself from killing by the T cell. And so the idea is, and you can see that in the the bottom part of the figure, antibodies that either block PD-1 or block PD-L1 basically just interfere with the ability of PD-1 to bind PD-L1. And so by doing that, it releases the brakes, basically, and that T cell is then able and free to go and carry out its function to kill that cancer cell. And so most of the work, again, in breast cancer has been in metastatic triple-negative breast cancer, and definitely, there have been proof of concept studies that have showed that this can work in triple-negative breast cancer. Next slide. Of course, all of this isn't without consequence. So if we sort of unleash our T cells, that may, of course, have a good effect against the cancer to kill the cancer cell, but our immune system is carefully regulated. And there are, of course, multiple medical conditions where the immune system is in overdrive, and this can lead to problems of autoimmunity. And so there are a number of autoimmune diseases that are observed in medicine. And what we have seen with using these drugs and upregulating the immune system in this way is that we can have a number of side effects involving multiple organs related to this autoimmunity. So basically, the immune cell recognizing different tissues in its own in the body, and that can lead to disease. So this is seen. These immune-mediated side effects with checkpoint blockade are seen in about 10% or so of patients. The most common ones are sort of autoimmune thyroid problems. So there can be inflammation of the thyroid. This could lead to either low or high thyroid levels. There can be some inflammation of the lung. Rare cases of heart inflammation have been observed. Problems related to diabetes have been observed if there's autoimmunity against the pancreas and the insulin-producing cells there. There can be inflammation of the liver, of the colon, so you can see a number of different organs and tissues can be affected by this. And so this is really the major sort of side effect of these drugs. And I think as we've gotten better at using them and are more aware of some of these issues, there's definitely a more proactive approach taken to monitor patients for these types of side effects, and some recent guidelines released just a few weeks ago, really trying to help physicians appropriately manage these types of side effects, because these are not at all the typical chemotherapy types of side effects that we see. Next slide. So, as I mentioned, there have been a number of studies in metastatic triple-negative breast cancer, early phase studies, looking at these drugs as single agents. So there have been studies with atezolizumab, which is a drug targeting PD-L1, as well as with avelumab and pembrolizumab. What we have learned over time is that really in an unselected group of patients heavily pretreated with chemotherapy with metastatic triple-negative breast cancer, response rates are really modest. So when you look at patients who've had prior chemotherapy, often multiple prior chemotherapies for advanced disease, we have response rates in the single digits. If you look at the patients who were treated in the first line, so that's there were studies looking at atezolizumab and pembrolizumab in the first line. Definitely the rate of response with these drugs as a single agent is much higher, in the 23 to 26% range. So certainly, We can see responses in triple-negative breast cancer with these drugs alone, but this is not kind of on par with the rates of response that are seen in melanoma or some of the other tumor types where it's a much higher response rate. Patients who do respond tend to have, again, durable responses that can last a long time. But you can see, from all of this in breast cancer, this is sort of a summary of where we are in triple-negative breast cancer. These drugs by themselves just is not the answer. There have been multiple attempts to look at whether the tumor cells themselves make PD-L1 or not, and does this have, a bearing on the likelihood of response versus not, and that really hasn't, it's been a little bit unclear. Certainly tumors that are PD-L1 positive tend to have a higher likelihood of response, but it isn't required for response. And there have been, in triple-negative breast cancer, definitely some early reports looking at combining these drugs with chemotherapy showing higher objective response rates. Next slide. And so this was one of the early combination studies. This was looking at atezolizumab, that PD-L1 antibody, with a standard chemotherapy drug. This is nab-paclitaxel, also known as Abraxane. And this was for patients who either had received no prior chemotherapy for recurrent or metastatic triple-negative breast cancer or had received prior treatment. There were 32 patients, and what you can see in the table is there were patients treated in the first-line setting with no prior chemotherapy for their recurrent or metastatic disease, second line, and then third line and beyond. And you can see that the rates of response here in this combination study are definitely higher, 46, 22, and 40%, with a response rate in the overall study of 38%. The numbers are small, but definitely provide some rationale to think about chemotherapy combinations with these drugs in terms of just increasing the number of patients more likely to respond. Next slide. And so where we are right now in triple-negative breast cancer, again, this is where most of the action to date has been. We have come to the point with the atezolizumab compound that a phase 3 trial looking at nab-paclitaxel with or without atezolizumab for patients with their first relapse or for their first treatment for metastatic disease. This trial has completed. Accrual patients are in follow-up and the data are pending. So this study, if positive, and it's expected to be reported sometime later this year, could potentially lead to the FDA approval of atezolizumab for the first-line treatment of metastatic triple-negative breast cancer. There is another phase 3 study with atezolizumab, this time combining it with paclitaxel, which is just Taxol, and again, that first-line setting. And then the other major program has been with pembrolizumab. This is the Keytruda compound, and there are basically 2 phase 3 studies ongoing, one that's looking at various chemotherapy drugs for patients treated in the first-line setting with metastatic triple-negative breast cancer with or without pembrolizumab, and then there's another study looking at pembrolizumab by itself versus chemotherapy of physician's choice in patients who've been pre-treated. And so these are sort of the big studies. There are multiple phase 2 studies going on with multiple other drugs, some other immunotherapy targets, other chemotherapy drugs. There are a number of studies looking at combinations with PARP inhibitors and triple negative as well as BRCA mutation-associated breast cancer. Next slide. And so one of these PARP inhibitor combination studies was this one. This is the Topacio study looking at niraparib with pembrolizumab for patients with triple-negative breast cancer receiving treatment in the first, second, or third line for recurrent or metastatic disease. There's also a parallel cohort in the study looking at ovarian cancer. And really the idea is that there's the hypothesis that treatment with niraparib could basically result in an immunologically cold tumor becoming immunologically hot and infiltrated with these lymphocytes. And there are multiple mechanisms that are thought to potentially facilitate this. And so that was really the rationale to think about combining a PARP inhibitor with a drug like pembrolizumab. Next slide. And so these were the very early data from the Topacio study that were presented at ESMO. That's the European Society of Medical Oncology meeting last year in the fall. These will be updated at ASCO 2018. But this is basically, this was a phase 1-2 study. So the first part of the study was trying to find an appropriate dose. And then the phase 2 study was expansion in about 50 patients with ovarian cancer and about 50 patients with triple negative breast cancer. And you can see here from these plots on the right side that all of the sort of bars, each bar is a patient, and each bar that is sort of going down below the line of 0 is tumor regression. Every line that's going up above the line of 0 is tumor growth. And so you can see on the right side of the slide, with both ovarian cancer as well as triple negative breast cancer, there are a group of patients that are having tumor regressions, some of them more substantial, and you can see that that is observed both in patients with BRCA mutations as well as some patients without BRCA mutations. Next slide. There was another early study that was reported, again, with the combination of a PARP inhibitor and one of these checkpoint blocking drugs, durvalumab. And this was presented in December of 2017 at the San Antonio Breast Cancer Symposium. This was a large study that was looking at this combination in various groups of patients, and this presentation is really reporting on what was observed in the group of patients who had an inherited or germline BRCA1 or 2 mutation that they had HER2 negative metastatic breast cancer. And you can see the sort of schema on the right. Patients entered into the study. They had a biopsy. They received olaparib as a single agent, 300 milligrams twice a day for a month, and then they continued on olaparib and had the durvalumab introduced. Next slide. And so what you can see, again, if you look at sort of the sort of responses according to how heavily pretreated the patient was, you can see that the patients that were less heavily pretreated, 0 prior treatments for advanced disease or 1 prior treatment. Again, the numbers are small, but definitely more than 2/3 of patients had objective response with this combination. That response rate fell in patients more heavily pretreated, and for patients that were very heavily pretreated, 3 prior treatments or more, no responses were observed. Again, the numbers were small, however. And this just shows on the right, the blue lines are sort of the patients who had a response. The sort of yellow-orange are those with stable disease, and the darker bars at the bottom, there are a couple. These are the patients who had progressive disease. So you can see that most patients are having either response or stability in their disease. And the big question, because it's not randomized, is whether this is coming from the PARP inhibitor, because all of these patients, of course, have BRCA mutations, or is there really something about this combination that is leading to the observed rates of response. Next slide. And so there have been, much more limited reports from early phase studies looking at patients who have advanced ER-positive disease, but there have been a few studies that have had some ER-positive patients. You can see that the objective response rate has been, again, modest for these drugs alone. And so in the pembrolizumab study, they only took patients that were PD-L1 positive. So of course that enriches the response. And in that setting, there was a 12% response rate. But in the trial with avelumab, they enrolled 72 patients with ER-positive breast cancer, and only a couple of the patients actually had an objective response. Next slide. So I think when those studies came out, people were pretty disappointed about, the potential of these drugs in ER-positive breast cancer, and the thought was that, well, maybe these breast cancers, they're just ER-positive breast cancers, they're immunologically cold, and there's just not much of a role for immunotherapy in ER-positive breast cancer. But then we saw this study that was reported at ASCO in 2017, and this was a neoadjuvant study. So these were newly diagnosed patients. They didn't have metastatic disease. They all had pretty much stage 2 or 3 breast cancer, considered to be high risk. The patients got standard chemotherapy, either with pembrolizumab or without. And what they found in this group of patients, that for the triple negative patients who received standard chemo with pembrolizumab, they had about a tripling of the rate of complete response that was observed at the time of surgery. So all of these patients received this treatment for several months prior to surgery, again in the newly diagnosed setting, and then they went to surgery and they estimated how many patients actually had a complete response. So there was about a tripling of the estimated PCR rate, or pathologic complete response rate, in the triple negative patients, but there was also a really substantial increase in the hormone receptor positive HER2 negative patients, so from 13% estimated up to 34%. So I think that was something that certainly got everyone's attention. We typically think that hormone receptor positive breast cancers have an overall low likelihood of having a complete response to neoadjuvant chemotherapy, and this was an agent, pembrolizumab, when added, was really leading to an increase in the likelihood of achieving that response. So very interesting data in the newly diagnosed setting. Next slide. So the other thing that I just wanted to mention is there is a big trial ongoing, another one in the early stage setting. So this one is open to accrual right now. And this is sponsored by the National Cancer Institute, and it's running through the Cooperative Group Network in the United States. This is the SWOG and NRG S1418 trial. So this is a trial for patients who had triple negative breast cancer, early stage, and they received standard neoadjuvant chemotherapy prior to surgery, and then they went to surgery and they did not achieve complete eradication of their tumors. There was at least a centimeter of cancer remaining in the breast or something in the lymph node. And so for patients who had this residual cancer after getting standard chemo, this trial is available, and patients are basically randomized. It's a 50-50 chance to get the pembrolizumab drug. So this is MK3475. This is pembrolizumab every 3 weeks for a year versus observation. And then patients are going to be followed for both recurrence as well as survival. And so I think this is a really important effort looking at the role of immunotherapy for patients with triple negative breast cancer who did not achieve a complete response to standard chemo. Next slide. And then I just really wanted to finish up and highlight this trial, which is ongoing. This is a phase 3 trial looking at the addition of atezolizumab to standard chemotherapy for patients with triple negative breast cancer, stage 2 or 3. This is one of the really first big phase 3 trials in the early stage setting to look at a PD-L1 blocking drug. So in this trial, patients get a taxane weekly, nab-paclitaxel, followed by AC. all given prior to surgery, and they're randomized to either receive atezolizumab every 2 weeks as an IV infusion versus placebo. They go to surgery, and the pathologic complete response rate is assessed. And then after surgery, patients who are on the atezolizumab arm, they actually continue that for several more months to complete a full year of treatment. And then these patients will be followed both for relapse again as well as survival. So I think that, definitely what we're seeing and kind of where the trials are going, we've basically learned over time that, doing immunotherapy earlier in the course of the disease is probably better in terms of the metastatic setting, not waiting many treatments until immunotherapy is tried. If you're going to try immunotherapy, to do it earlier in the course of advanced disease. And again, where a lot of the data is currently pointing is that maybe these drugs may have the biggest role to play for patients that are newly diagnosed to help to prevent recurrence and improve survival. So, there are a number of studies. There's going to be a big phase 3 study rolling out soon, looking at standard chemotherapy with or without pembrolizumab for ER-positive breast cancer, and multiple other combination studies that are being looked at. And so I think, for breast cancer, the key is combination, doing these drugs by themselves have more modest activity, and then trying to look at them earlier in the course of disease. And then finally, just sort of looking at the toxicities. These are sort of different types of toxicities than chemotherapy. And I think as we gain more familiarity with these drugs, we'll be better able to predict as well as prevent these side effects. Next slide. And that's all I have.